This tutorial on complications of follicular unit excision is Chapter 7E, Part 5 out of 7 on performing FUE surgery in the Practical Guide for Hair Transplantation by Drs. True, Garg, and Garg. We will be reviewing general complications, damage to the donor area, and grafts. The most common and important complications are from poor surgical technique, which include donor area overharvesting, excessive transection and follicle damage during harvesting, and damage to grafts during handling and placement. General complications include vascular necrosis, nerve damage, anagen effluvium or shock loss, and infection. This is an example of donor area necrosis with FUE. At the end of surgery, there appears a dusky area which gradually coalesces, forming a necrotic area, which will ultimately leave a scar in the donor region. This is a necrosis in 3 different cases in the recipient area with FUE. What are the contributing causes for vascular necrosis? Well, overdense graft harvesting or overdense graft placement, very deep punch insertions for harvesting, or very deep and large recipient sites for graft placement, overzealous use of high concentrations of epinephrine, direct vascular injury, and smoking. How do we treat vascular necrosis? Nitroglycerin paste applied promptly can be helpful. Hyperbaric oxygen has been beneficial in managing cases. Cases have to be monitored very closely, and cleaning and debridement of the wound is also very important to manage healing. And ultimately, these scars will need tissue repair. Temporary sensory loss or hypersensitivity in the donor region or recipient areas is common, and this resolves within a few months. Permanent sensory loss or neuralgia are very uncommon and are related to direct nerve injury. Severe persistent neuralgia may require injections, even repair to resolve. Anagen effluvium, or shock loss, is the term applied to the loss of native hair as a consequence of surgery. This can happen in the donor or recipient area. Most of the time, the loss is temporary and fully recovers. However, incomplete recovery is more likely in the recipient area when miniaturizing hair is involved. This is an example of shock loss with FUE. We can see that 10 days postoperatively, the patient has lost almost all of the hair in the donor region, a frightening appearance, certainly to the patient, but fortunately, by 6 months later, there has been full recovery. What contributes to the development of anagen effluvium? Well, excessive use of high concentrations of epinephrine, overdense harvesting, and some patients will develop it without any clear evidence of what has contributed to it. This is quite unusual, but it can happen. How do we treat it? Topical application of minoxidil, reassurance to the patient. Masking cosmetics can be beneficial in the interim, and we should have expectant observation for 3 to 6 months for recovery. Infection is very uncommon with hair restoration surgery, but it can occur either in the donor area or recipient area. This is the typical appearance of a honeycomb appearance in the recipient area, which is typical of a staphylococcal infection. What contributes to the development of infection? Well, certainly unsanitary surgery can be a factor, but also it can be related to negligent postoperative care on the part of the patient. If MRSA, resistant Staphylococcus aureus, is the cause, it almost always is community acquired. In treating infection, we have to first of all assume that the agent is MRSA. We should obtain a culture immediately, and thorough wound cleaning and debridement is very important to resolve the infection. Until culture results are obtained, the patient should be begun on empiric trimethoprim sulfamethoxazole or doxycycline. Damage to the donor hair can be excessive harvesting and donor depletion, inclusion cysts, keloid or hypertrophic scarring, and hypo or hyperpigmentation. In the example on the left, the harvesting has been confined to a fairly narrow part of the donor zone rather than dispersed, and so the patient is left with a visible zone of low density compared with the adjacent hair. This is a focal over-harvesting rather than a dispersed harvest, which is always desirable. On the right, there has been focal over-harvesting in clusters, so in groups of follicles adjacent to one another have all been harvesting, leaving these little bald patches, which produces this moth-eaten appearance. This is over-harvesting and donor depletion in a single session of 4,000 grafts, and also this patient has poor growth. And this is 4,500 grafts in a single session with a severely damaged and exhausted donor supply and leaving the patient with a disfigured appearance. This is over-harvesting in one region. A larger punch was used. Adjacent follicles were taken. A number of errors here. And so the patient is left with a very odd appearance of over-harvesting. These situations can be sometimes successfully resolved through the application of scalp micropigmentation. Inclusion cysts arise from buried grafts which occur at the time of excision. This occurs more often when using blunt and hybrid punches and is due to incomplete punch engagement in the first phase of graft excision. Every buried graft should be removed if at all possible at the time of surgery. Sometimes these will produce quite large boils and infected areas that will require intervention later on and should be avoided at all costs. I have been practicing FUE for 20 years now, and I had never seen a case of hypertrophic scarring in FUE until just 2 years ago when I encountered this in my patient. Here, clearly there's hypertrophic scarring. This is a rare occurrence, but it can occur. And recently, a colleague sent me these pictures, which shows true keloiding in FUE surgery. I also consider this to be very rare. I've never seen it, but we do now have to recognize that it is possible that it can occur. Hypertrophic scarring is a much more common occurrence, and this is especially true if large punches are used, if the extractions are placed too close together, and it also sometimes is just a factor based on patient skin characteristics. We can avoid this by using small diameter punches, dispersing the harvest as much as possible, and we can help to hide this if it does occur with scalp micropigmentation. Damage to graft can include excessive transections, stripping and denuding of the grafts, desiccation of the grafts, and extraction and placement trauma. All of these can contribute to poor growth and surgical outcomes. These are poor quality grafts. Every one of the grafts has 1 or 2 transections in it. These are poor quality simply because the grafts are totally denuded at the base. The bulbs and adjacent follicles are stripped of any supportive tissue. And when this occurs, then the follicles get this extreme iatrogenic splay because there's no tissue to hold them together. And these present challenges for graft placement. These are high quality grafts. There's no transections. There's good supportive tissue throughout. And these are grafts that should produce very well when transplanted. If recipient sites are too deep and or too large, then the grafts can produce folliculitis, pitting, and poor growth. This is poor growth from faulty harvesting and faulty handling and graft placement. Very poor yield, and we see pitting of the skin. When recipient sites are too shallow and are too small, bumps or cobblestoning can occur on the skin and also poor growth. Here are some tips on how to avoid overharvesting. Determine the number of grafts needed, determine the type of grafts needed, measure the donor density in hairs and follicular units per square centimeter, and limit your harvest to 10 to 15 grafts per square centimeter. Mark a grid to assure an even distribution and a dispersed harvest. Here's an example. If we need 800 grafts for the hairline, we want to have 300 to 400 to be singles. Donor density is 70 follicular units per square centimeter in the occiput and 60 in the temporal region. At 15 excisions per square centimeter, we will need 54 square centimeters to have a dispersed harvest. And at 10 excisions per square centimeter, we'll need 80 square centimeters. Harvests of this density in a single pass should not create cosmetic donor problems as long as they have not been done with larger than necessary punches. We need to also think about avoiding placement problems, and tips to beginners about placing grafts into pre-made sites are important. Sites must be customized for each patient. In order to avoid problems in graft placement, it is crucial to perform test sites first to set the correct size, depth, and size of the sites. The key variables that affect graft placement with pre-made sites are the size of the sites, the depth of the sites, and whether we're using forceps or implanters. To avoid placement problems, make test sites and do test placement. Measure and observe all sizes of grafts, test place all sizes of grafts, adjust the recipient site size and depth until correct placement is achieved, test different scalp locations, and then when you're clear that all the parameters are set correctly, proceed with pre-made sites. The grafts should be assessed microscopically or with high-powered loops as far as their length, shape, the degree of splay, the quality of the grafts, and measure the test grafts so you know how long they actually are. This can vary from patient to patient. I use chisel blades custom cut for recipient sites, and I set the initial depth of that blade 1 millimeter less than the graft length and adjust from there. Chisel blade incisions and needle incisions are different. With chisel sites, there's uniform size throughout, and the graft can be inserted comfortably to full depth of the site. But with needle sites, the bottom of the site narrows because of the point of the needle, and grafts may not fit into this portion of the site, so needle sites may actually need to be deeper than chisel sites to comfortably accommodate the grafts. In this case, the test grafts are too elevated. We have to deepen and perhaps enlarge the sites and retest. Here, the test sites are too deep. The grafts are actually sitting under the epidermis, and so we need to reduce the site depth and possibly adjust the size. Here, the test grafts are sitting at the correct level. They are ever so slightly elevated above the surface of the skin, and now we can proceed with pre-made sites. You should remove your test grafts and look at them. If you see hooked at the bottom, this means that the grafts are being forced into the sites, and the sites are not really deep enough, so you need to adjust and retest. Look also if there's any damage to the bulbs, such as crushes or fractures. This would indicate that the placement is traumatic, and the site should be adjusted or the method of placement adjusted in order to minimize this. The majority of complications are technique related and preventable by careful attention to technical detail during surgery. With proper surgical technique, complications with FUE are uncommon. General complications include vascular necrosis, anagen effluvium, nerve damage, and infection. The most common complication in the donor region is donor depletion caused by overly aggressive harvesting. Damage to the grafts can occur at all stages of harvesting, storage, and implantation. FUE surgery should be performed by licensed and trained and skilled doctors and not delegated to unlicensed technicians. Smoking is a risk factor for the complications of vascular necrosis and poor growth.